Good day, ladies and gentlemen, and welcome to this webinar on sequencing osteoporosis therapy. I'm Dominique Pierrot, Science Manager at IOF, and I'm very glad to moderate this webinar today. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted, but I would like to encourage you to ask questions during the webinar by typing them into the question box of the control panel, and I will voice them to the speaker towards the end of this webinar. This being said, I have the great pleasure today to welcome Dr. Michael McClung, who is the founding director of the Oregon Osteoporosis Center in Portland, Oregon. He is also a professorial fellow at the Mary MacKillop Institute for Health and Aging at the Australian Catholic University in Melbourne. He has been involved in many important clinical studies that led to the availability of medications for osteoporosis and Paget disease of bone. He has published more than 200 peer-reviewed papers, and he is an editorial board member for several journals in the field. Dr. McClung has been a member of the IOF Committee of Scientific Advisors for more than 20 years, and he currently serves on the boards of the IOF and the North American Menopause Society, among many other duties. Dr. McClung, thanks again for agreeing to present today, and we are listening to your presentations.
All right, Dominique, thank you for that introduction. It's a pleasure to be here. Good day, everyone, and I'm looking forward to discussing the concept of sequencing osteoporosis therapies. Please note my financial relationships noted at the bottom of the slide. Most importantly, a long-standing relationship as a consultant and a speaker for Amgen, who of course has drugs that will be mentioned in the course of today's discussion. So let's start with some important points before we get to the mechanisms of sequencing. First of all, we all appreciate that osteoporosis is a chronic, currently incurable condition that requires long-term, if not lifelong, management. We've also learned in the last several years that we actually have ways of monitoring the responses of therapy that are meaningful, in that on-treatment hip bone density values have been shown to correlate with current fracture risk. One of the attributes of all of our osteoporosis therapies is that the benefits of those treatments gradually diminish upon discontinuation of treatment. For some drugs like denosumab, this happens very quickly. But for drugs like bisphosphonates, it happens less quickly, but it still happens. And that means that it's very important to have a strategy for long-term treatment. We can't just give patients treatment for a few years and then stop. As you know, we have an impressive menu of treatment options. The drugs have different mechanisms of action, different contraindications, different potency and effectiveness. And so we have a choice of those drugs. And we have come to appreciate recently that the sequence with which drugs are given may have important clinical ramifications and meaning, and we'll consider some of those. Here's the list of drugs that you're familiar with and the division of our current osteoporosis treatments into two major categories: anti-remodeling agents that inhibit not only bone resorption, but bone formation. Because of that, because of the inhibition of bone formation by all of the anti-remodeling agents, these drugs cannot and do not restore the architectural damage that is osteoporosis. In contrast, the osteoanabolic or bone forming drugs that fall into two categories, either the parathyroid hormone receptor activators, teriparatide, and in my country, abaloparatide, or a modeling stimulator that increases bone formation while decreasing bone resorption, romosozumab, the sclerostin inhibitor. These drugs do have the capability of restoring not only bone mass back toward normal, but actually improving skeletal architecture as well. So there are a variety of ways in which sequences of these drugs can be used, but rather than talk about each specific possible sequence with all of the different drugs, I've chosen to provide discussions about four situations in which a sequencing or switching therapy might be considered. The first of those would be for patients who begin an anti-remodeling agent. That's the usual way we start therapy. And if it's thought that after an interval of time, the response to that initial treatment is inadequate, then it would be appropriate to consider switching. A second related situation would be after 5 years of bisphosphonate therapy, and I will argue that there is little justification for any patient to be on a bisphosphonate for more than 5 years at a time, but we'll come back to that. Then, when non-bisphosphonate anti-remodeling drugs are stopped, that would include stopping estrogen, raloxifene, or denosumab, we know that the benefits are very rapidly lost, and switching to a drug to maintain those benefits would be important. And then finally, the switch from an anabolic agent to an anti-remodeling drug is now thought to be necessary and routine at the end of a course of anabolic therapy. So let's consider those four situations. The first of those would be an inadequate response to an anti-remodeling drug. A patient, an 80-year-old man with osteoporosis, begun on a alendronate. After 2 years, the bone density values had not changed. He still had osteoporosis by bone density criteria, still was a candidate for therapy. And so the approach, of course, would include several things. First, we would obviously assess the patient's compliance with the dosing regimen. We know that compliance is often inadequate or poor in this situation. If compliance was not the explanation for the lack of response, then we would look again for underlying secondary causes that might influence or blunt response. So we'd look for vitamin D deficiency, we would look for hypercalciuria, we would look for other diseases that would alter a response to therapy. We would also consider the possibility that the patient is simply not absorbing this orally administered drug, and we can evaluate that by perhaps measuring a marker of bone turnover. We would expect a marker of bone resorption, of course, to be in the low normal range, and if that's not the case, then we would have more indication, perhaps, of poor absorption. And after considering all of those things, then we might then consider switching therapy, perhaps particularly in the case of poor absorption, switching to perhaps a parenteral administered drug. We did a study several years ago switching from alendronate to zoledronic acid in healthy people, and we demonstrated that there was no particular bone density benefit in that switch. So we might expect a better result if we switched from an oral bisphosphonate to zoledronate in patients who had been poorly compliant with their oral drug or who had evidence of malabsorption of the oral drug. But in the absence of those findings, there's no advantage or no apparent benefit from switching from an oral to an intravenous bisphosphonate. Switching from an oral bisphosphonate to denosumab has been shown to result in a somewhat more rapid increase in bone density in both the hip and the spine, at least over the first 12 months of therapy. So this gives us reason to consider switching from an oral bisphosphonate to perhaps denosumab in the situations where we're considering change. So switching from an oral bisphosphonate is appropriate when the patient is intolerant to therapy, has difficulty being compliant with the dosing regimen, or is thought to have an inadequate bone density or skeletal response. The follow-on therapy, whether it's an IV bisphosphonate, denosumab, or an anabolic agent, will depend upon the entire picture of the patient, their current bone density, fracture risk, other medical issues, for example, renal function. The patient preference, of course, should be included, as well as the cost of therapy. And in general, the response to any treatment when given after alendronate or an oral bisphosphonate tends to be smaller in terms of bone density response than when the bisphosphonate is administered to a treatment naive patient. That's not a surprise. We know that the bone density response to both anti-remodeling and anabolic therapies is related to the level of turnover at the time treatment is started. Patients with high turnover have a bigger response. Patients with lower turnover, a smaller response. So it stands to reason that if patients have been on an oral bisphosphonate and have an inhibition of bone turnover, that their subsequent bone density response would be smaller. So a different scenario would be an 80-year-old patient begun on alendronate. 2 years later, she experienced 2 vertebral fractures, and her bone density values are still clearly in the osteoporosis range. This is a situation where now we would consider switching to an anabolic agent because the patient, by virtue of her recent vertebral fractures, now meets the relatively newly defined criteria for being at very high fracture risk. You're aware that both the American endocrine societies as well as the International Osteoporosis Foundation have suggested that a category of very high risk be considered in patients with recent fractures or with very low bone density. And in those patients, that the choice of therapy would be an anabolic agent based upon data documenting that anabolic therapy is more effective than anti-resorptive therapy in reducing fracture risk. So when we consider switching to an anabolic agent from an anti-remodeling drug, we again base that on studies in treatment naive patients demonstrating better bone density and fracture protection with osteoanabolic drugs than with a bisphosphonate. We know that the bone density response to anabolic agents is smaller in patients previously treated with an anti-resorptive agent compared to treatment naive patients for the reasons we talked about earlier. And there are very limited data evaluating the effect of that transition from an anabolic drug to an osteoanabolic agent on fracture data. We mostly have bone density and bone marker responses rather than fracture data. So the reason to consider switching from an anti-remodeling drug to an anabolic agent would be an inadequate response to the anti-remodeling agent or a marked increase in patients' fracture risk, putting them now into the category where they meet the criteria for being treated with a bone-forming drug. The second case where we consider switching therapies, I contend, would be after 5 years of bisphosphonate therapy. We know that after 5 years of bisphosphonates, for patients who no longer meet treatment criteria, a temporary interruption of therapy, the so-called bisphosphonate holiday, is thought to be justified. However, for patients who remain at high risk of fracture after 5 years of therapy, that is, who still meet the criteria for treatment, it's recommended that treatment be continued. However, we know that beyond 5 years of bisphosphonate therapy, there is no additional increase in bone density, nor any additional improvement in fracture risk reduction with longer-term therapy. Yet, with longer-term therapy, there is a duration-dependent increasing risk of atypical femoral fracture. Those 2 points are illustrated here. Shown in the top panel is the total hip bone density value in patients receiving zoledronate for 9 years, 9 annual doses, with a peak in bone density or plateau in bone density perhaps at year 5, with no additional benefit beyond year 5. Shown in the lower panel is the age-adjusted incidence of atypical femoral fracture as a function of the years of bisphosphonate therapy, showing the marked increase in that risk beyond 5 years of therapy. So for patients who are still in need of treatment after 5 years of therapy, continuing bisphosphonates won't make them be better in terms of bone density or fracture risk reduction, but only exposes them to increasing risk of potential side effects, leading me to the conclusion that there is not a justification for continuing bisphosphonates beyond 5 years at a time in any patients, and that we should then consider switching for those patients who deserve continued therapy. So an example would be a healthy 75-year-old woman with osteoporosis and a prior humerus fracture, begun on alendronate 70 milligrams weekly. After 2 years, after 5 years, her bone density has improved. So she had the expected response to bisphosphonate therapy, but she still remains with osteoporosis and still is a candidate for ongoing therapy. So she is not a candidate for a holiday. And in my view, switching to denosumab or to an osteoanabolic agent would be considered. Again, we know that with denosumab, unlike bisphosphonates, there is continued increase in bone density over 10 years of therapy in the Freedom long-term extension study. We also know from a quartet of studies that switching from a bisphosphonate to denosumab result in a larger increase in bone density than occurs if the bisphosphonate is continued. So that increment is not dramatic, is in the range of 1 to 2% during the first 12 months after the switch, but there is consistency among these studies in showing better improvement if patients are switched to denosumab. We also know that if patients have been on bisphosphonates in the structure study for an average of 6 years, and then are switched to either romosozumab or to teriparatide, there is a quite measurable increase in bone density in the lumbar spine over the 12 months of anabolic therapy. In the total hip region, there was little effect of switching to teriparatide on hip density, but a measurable increase in bone density when the patients were switched from alendronate to romosozumab. Again, demonstrating better improvements in bone density when a switch in therapy was made rather than continuing the long-term bisphosphonate therapy. So for these patients, the patients who remain at high risk of fracture after 5 years of bisphosphonate therapy, there is, in my view, no justification for continuing the bisphosphonate. Switching to either denosumab or to an anabolic agent is recommended, the choice being driven by the patient's current risk of fracture. It appears that the bone density response when switching to romosozumab is greater than that occurs with the switch to teriparatide, which might inform us of our treatment decision. However, again, I'd emphasize that we don't have adequate fracture data regarding this transition of switching from a bisphosphonate to an anabolic drug. The third issue would be to consider a transition and sequence of therapy upon discontinuation of estrogen or denosumab. So a woman who was begun on denosumab therapy for osteoporosis, after 4 years of therapy, her bone density had substantially increased, and one might then consider switching because she perhaps was no longer in a high-risk category. There is no limit, of course, to the duration of denosumab therapy. We have very good clinical trial data out to 10 years, but just because the study only lasted 10 years does not mean that 10 years is the maximum time that denosumab would be used. So the reason to discontinue denosumab would include, of course, the development of an adverse event that was thought to be related to the drug, or perhaps that the patient reaches an acceptable bone density or fracture risk target. Other issues, of course, would be related to insurance coverage and cost of the drug, etc. So the considerations are, as I've said, there's no limit to the duration of denosumab use. Despite the improvement in bone density in this patient, she still has osteoporosis. Denosumab does not correct the architectural deficit that is what osteoporosis is, and we know that upon discontinuing denosumab therapy, she would experience a rapid loss in bone density back toward her original baseline and very rapid loss of vertebral fracture protection. So the choice would be either to continue therapy or to make a decision to switch. We know again from studies we did early on that after 2 years of denosumab therapy, if treatment is discontinued, there's a very rapid loss of all of the bone density gain within an interval of 12 months or so. And that's due to a rebound in bone remodeling that takes a year or two to come back to pre-treatment remodeling levels. These data and this experience is very similar to what we already knew about discontinuing estrogen. In studies that were done many years ago, when estrogen is discontinued, there's a rapid loss in bone density that can be maintained or prevented by switching to alendronate therapy. This loss of bone density and stopping estrogen is also associated with a rebound, a temporary rebound in bone remodeling, and in the Women's Health Initiative, a rapid loss of fracture protection, which had been afforded by estrogen therapy during the years that the women took estrogen. So this is not a phenomenon unique to denosumab, but is a consequence of all non-bisphosphonate anti-resorptive therapies. Of course, there's been lots of discussion about what to do if denosumab therapy is stopped. I think there's a strong consensus that a potent bisphosphonate and typically zoledronate would be the treatment of choice. There's several sets of data suggesting that after short-term denosumab therapy, that either oral alendronate or a dose of zoledronate is effective in preserving bone density or preventing the rapid loss of bone density that one would anticipate. In contrast, in patients who have been on denosumab for a longer interval of time, then zoledronate is only partially effective in preventing bone loss, and the individual variation to response to zoledronate is quite large. Some patients seem to be protected. Other patients lose bone very quickly despite zoledronate therapy. And of course, that response is complicated, as was shown in the very nice prospective study by Dr. Soling and Langdahl and others. Shown in red as the hip bone density and CTX values in women who had been on denosumab for an average of more than 4 years, who were given 1 dose of zoledronic acid 6 months after the last dose of denosumab. And on average, there was a gradual decrease in hip bone density, not nearly as quickly as happened in patients who either did not receive therapy or had a delay in the administration of zoledronate. And it was noted that some patients probably require a second dose of zoledronate to adequately protect them from the rebound in remodeling and rapid bone density loss that happens upon stopping denosumab. But consideration for a potent bisphosphonate upon stopping denosumab is now thought to be a key element of management in patients who have been on denosumab for at least 2 years or longer. So, after 2 years or more of denosumab, all patients should receive either zoledronate or alendronate if therapy is discontinued, with close monitoring of both bone remodeling markers and bone density, with the consideration of a second dose of zoledronate if either significant bone loss or a rise in CTX to above the premenopausal reference range is observed. There is a small amount of experience in switching from denosumab to teriparatide. Because teriparatide does not inhibit bone resorption, but rather actually stimulates bone resorption, it is incapable of blunting the rebound in bone remodeling that occurs with denosumab. And as a result, there is a transient, quite rapid loss of bone density in cortical sites when that transition is made. And so that transition from denosumab to teriparatide is not recommended. In a very limited set of information, it appears that bone density is preserved when patients are switched from short-term denosumab therapy to romosozumab. We don't yet have information about switching from long-term denosumab therapy to romosozumab. And then finally, I think the least controversial part about switching or sequencing therapy comes upon completion of a course of osteoanabolic therapy. So a woman who had a prior history of wrist and pelvic fractures and then 3 vertebral fractures was identified as being at very high risk of fracture. She was begun on abaloparatide 80 microgram daily, which she has taken for 18 months, the approved duration of therapy, with substantial improvements in bone density. So she certainly met the criteria for being at very high risk of fracture. So a choice of an anabolic drug was very appropriate. But the bone building effects of all of the anabolic agents is limited and gradually wanes with longer term therapy. And thus the interval of anabolic therapy is generally thought to be 12 to 24 months. And then if therapy is discontinued, then the skeletal benefits rapidly go away. We know that, again, anabolic therapy is thought to be indicated for patients at high risk of fracture because of these 2 studies documenting that anabolic agents are more effective than bisphosphonates in reducing fracture risk in patients at high risk of fracture. The Vero study demonstrating better reduction in both vertebral and clinical fracture risk with teriparatide compared to risedronate. In the ART study, significantly better reduction in fracture risk with romosozumab compared to alendronate. So we've got strong data arguing for the rationale and justification for the use of anabolic agents in these patients. However, then when treatment is stopped, there is a rapid loss of the bone density effect and probably the fracture protection effect. Shown on the left are changes in spine bone density after discontinuing teriparatide after 12 months. Shown on the right, the decrease in both spine and hip bone density upon stopping 2 years of romosozumab therapy, with values tending back to the baseline values within the 12 months upon discontinuing treatment. We know from a variety of studies that the bone density response to each of the anabolic agents is at least maintained, or with denosumab appears to be improved when the anti-resorptive drug is given after a 12 to 24 month course of anabolic therapy. The improvements in bone density with this sequence is really quite dramatic. Shown in the right part of the slide are the average changes in lumbar spine bone density after 10 years of either denosumab or alendronate therapy. And note that within a couple of years' time, we can achieve those same values with a 12-month course of romosozumab or a somewhat longer course of a PTH-like drug, followed then by either denosumab or alendronate. Again, without having head-to-head comparisons, we're left with comparing across studies, which is always problematic, but there is some suggestion that the bone density response to denosumab following an anabolic drug is greater than the smaller response seen when the patients are transitioned to alendronate. In the total hip region, we see similar effects. Teriparatide has a very limited effect on total hip density, but when switched to denosumab, there is a substantial increase. The abaloparatide to alendronate study showed a modest additional improvement upon switching to alendronate. And in the two studies with romosozumab, again, alendronate and romosozumab either maintained or improved bone density after the 12 months of bone building therapy. Very importantly, the fracture protection afforded by 12 to 24 months of anabolic therapy persists for at least 2 years once the patients are transitioned to an anti-remodeling agent. So shown in the middle panel is the FRAME study, where patients with osteoporosis were randomly assigned to receive either romosozumab or placebo during the first year of study, during which there was a 73% relative reduction in vertebral fracture risk. During the second year, all patients in both groups received denosumab, and at the end of that second year, the relative risk reduction in the women who had previously received romosozumab was 75% lower than in the women who were on placebo followed by denosumab. During the second year alone, pre-treatment with romosozumab resulted in an 80% lower incidence of vertebral fracture, despite the fact that all women in both groups were receiving the same therapy during that second year. We see the same thing in the active extend trial, where abaloparatide reduced vertebral fracture risk compared to placebo by 86% over 18 months during 2 years of additional therapy, during which all patients received alendronate. That relative risk reduction was maintained, and during the 2-year interval where all patients received alendronate, pre-treatment with abaloparatide reduced vertebral fracture risk by 87%. And then lastly, on the right in the ARCH study, similar findings, 37% reduction with romosozumab compared to alendronate during the second year. While all patients received alendronate, the relative risk reduction was maintained. So the fracture protection benefit of anabolic agents can be maintained upon switching to an anti-remodeling drug, providing very strong justification for that sequencing of therapy. So switching to either bisphosphonate or to denosumab should follow any course of osteoanabolic therapy to maintain or to improve bone density and to maintain fracture protection. The choice between bisphosphonate or denosumab is made on the basis of the patient's current fracture risk and bone density, especially hip bone density, where denosumab appears to have a better effect than does switching to alendronate. And after an anabolic agent, the bone density response again to denosumab appears to be greater than is seen with alendronate. So to come back and summarize, I've identified 4 situations where we consider a sequence of therapy and switching therapy. Firstly, if a patient experiences an inadequate response to an anti-remodeling drug, we would then switch often to a parenteral drug, either an IV bisphosphonate or to denosumab, or if the patient was at very high risk, and anabolic therapy. After 5 years of bisphosphonate therapy, I strongly suggest that we should consider switching to denosumab or an anabolic drug for those patients remaining at high risk of fracture demanding ongoing therapy. when a non-bisphosphonate anti-remodeling drug is stopped, then it would be important to protect them from the rapid loss of skeletal benefit, and that's usually accomplished by transitioning to a potent bisphosphonate. And then at the end of a course of anabolic therapy, patients should be transitioned to either a bisphosphonate or to denosumab, and the choice of the next agent will depend upon the initial drug, the patient's response to that drug, and the patient's our assessment of the patient's current fracture risk and other clinical status. So again, osteoporosis management requires a long-term time frame with long-term, if not lifelong, therapy. Regardless of whether a patient is begun on an anti-remodeling drug or an anabolic therapy, we've got various sequent options that we can choose among. There's very limited data about switching from one anabolic agent to another. A very small study from Japan suggests that bone density does increase if patients are switched from teriparatide to romosozumab, but that's not been looked at very carefully. But the other sequences of switching between anti-remodeling agents, anabolic agents to a remodeling agent, or back, we have discussed. It's my personal thought that at the end of any sequence, even a sequence that involves multiple drugs and even the use of anabolic agents on multiple occasions, the final drug in any sequence would likely be zoledronate, where we can take advantage of its long-term effect on inhibiting bone turnover and maintaining the gains that had been made with the previous sequence. With that, I thank you for your attention and would look forward to our discussion. So Dominique, I'll turn it back to you.
Thank you very much, Dr. McClung, for this very comprehensive presentation. We already received many messages in the question box from the audience. People are really thanking you for your great talk. And I would like to move on to questions because we have received many of them. So I will try to select some of them, maybe the most relevant one for the entire audience. So Dr. Langdal asks you, what is the evidence for repeating bone anabolic treatment in patients at high risk of fracture?
As usual, Dr. Langdal has a very insightful question. There's very limited evidence. There's a study by Dr. Cosman who gave a second course of teriparatide after an interval off therapy of about 12 months and showed that the anabolic response had come back again. In the phase 2 romosozumab study, we treated patients for 2 years. In that phase 2 study, we didn't, of course, appreciate how quickly the anabolic effect waned. At the end of the second year, patients, as I've showed, when we discontinued therapy, all the benefit was lost. They were then retreated with romosozumab, and the full anabolic response occurred again. So that's the very limited information we have. In patients who are on an anabolic agent and who are then followed for 12 months or so with an anti-remodeling agent, we have very limited information about what happens next. In the phase 2 romosozumab study, when patients went from romosozumab to denosumab and then to romosozumab, bone density was maintained, but the anabolic effect was much, much smaller than it had been in the treatment-naive patients. But if a patient, after 12 or 24 months of an anti-resorptive drug, having been previously treated with an anabolic agent, if that patient still remains at very high risk of fracture, I think that there is at least a justification to consider a second course of the anabolic drug.
Thank you. A question from Dr. Bock is asking, how do you proceed with pharmacological treatment in patients who developed an atypical femoral fracture while being under long-term denosumab therapy? What are your considerations and recommendations? And do you have any experiences with romosozumab in these patients?
Yeah. Dominique, I thought we had agreed that you were only going to ask questions that I could answer. So this is much too hard of a question. But in seriousness, I don't know the answer, and I think we have so little information about this. I think one cannot or should not simply discontinue denosumab, even in a patient with an atypical femoral fracture, without taking into consideration the serious potential of rapid loss of vertebral fracture protection. So the only information that I can share with you about the switch from denosumab to romosozumab I've already mentioned, where after 24 months of romosozumab followed by 12 months of denosumab, then the patient was put back on romosozumab and bone density was maintained, and the marked rebound in bone remodeling that normally occurs upon stopping denosumab did not occur. But again, as I mentioned, we do not have information about the use of romosozumab after long-term denosumab therapy. And as Dr. Langdahl and her colleagues showed, the remodeling and the rapidity with which bone density is lost seems to be dependent upon the duration of the denosumab therapy. So that makes that be a very tough problem. So in a patient who experiences an atypical fracture while on long-term denosumab therapy, I think the choice is either to continue denosumab or to continue switching to a bisphosphonate, neither of which are very attractive options. But I think we can't simply and shouldn't simply stop the therapy because of the risk of vertebral fracture, assuming the patient is at high risk of vertebral fracture. So I effectively didn't answer the question. I know that, but because I don't know the answer.
Yeah, sure. But yeah, people also, are eager to, to get your feedback or your point of view on difficult questions. You are an expert. That's why they are asking difficult questions. There is another one from Nancy. I don't have her last name. So she's asking, after 1 year on denosumab, if you switch to an osteoanabolic, would the anabolic response be more effective than if you switch after 2 years on denosumab?
Good question. I don't know. Again, I don't know what determines the blunting of the response. If it were as simple as the level of bone turnover at the time the switch was made, then it shouldn't matter, because the effect of denosumab on inhibiting bone turnover, of course, happens acutely, and there's not more suppression or inhibition of bone turnover after 2 years than there was after 1 year. So if the response is driven by the level of turnover at the time the switch is made, I would not expect a difference. But I don't know with certainty what the explanation is for the blunting of the anabolic response after an anti-resorptive drug.
Thank you. Dr. Agnus Day is asking whether you have any experience with patients treated for more than 2 years with an anabolic agent.
Yes, I don't have experience with romosozumab in that regard, but I do have experience with teriparatide in several settings. First of all, we've even got the clinical trial of 3 years of therapy with teriparatide in patients with glucocorticoid-induced osteoporosis in the 2 studies by Dr. Sag and his colleague. in our clinic, we have used repeat courses of teriparatide in many patients, patients in whom fracture reduction seemed to be very dramatic while they were taking teriparatide, and then during 6 months or 12 months on a bisphosphonate, fractures began happening again, and we would then retreat them with teriparatide for 12 to 24 months. More recently, for patients after 2 years of therapy with teriparatide, I frequently use a marker of bone formation like serum P1NP, and if the values are still elevated, then I'm quite confident that the bone forming effect of the drug is still happening, and I would feel compelled to continue their teriparatide therapy rather than arbitrarily making the decision to discontinue at that time. So those are my experience and thoughts about that.
Dr. Kalmandi is asking, what is she asking? Sorry, I lost the question. If a patient has severe osteoporosis, can we give more often zoledronate than once a year, maybe twice a year?
I'm sure one could, but I don't know that that would be effective. In the phase 2 study, remember, one dose of zoledronate markedly reduced indices of bone turnover that lasted for the full year. So there would be little additional benefit to giving a dose of zoledronate 6 months after the first dose, except in patients with secondary forms of osteoporosis, like myeloma, where bone remodeling rates are very, very high. But I think for typical osteoporosis, I don't see an advantage in more frequent administration of zoledronate.
Thank you. Another question related to zoledronic acid. What evidence do you have in patients after 5 years on zoledronic acid that they would be responsive to any new treatment?
We've got almost no.
How much will they benefit to switching to another therapy?
Yep. I'm not aware of any data that has actually evaluated that specific question. In fact, there's very little data about looking at the effect of any therapy following zoledronic acid. Almost all of the transition studies and sequencing studies that I alluded to were patients who had been on oral bisphosphonates switching to something else. We do have the one study that looked at the transition. That was the transition from an oral bisphosphonate to either denosumab or zoledronate, not transitioning from zoledronate. So again, I think we don't have data about that. It's probable that the bone density response to any therapy we would choose after zoledronate would be dictated and driven by the level of bone turnover in that individual patient at the time the transition was considered.
Thank you. There is a follow-up question by Dr. Langdahl. I'm sure you will appreciate. She's asking, would the consideration about a second course of romosozumab or teriparatide affect your choice of an anti-remodeling drug after the first course of bone anabolic treatment?
Again, Bente, that's a great question. I've thought about that and would then consider the use of a bisphosphonate rather than denosumab as the intervening drug if I were quite confident that I was going to plan a second course for reasons that I'm sure you appreciate. We don't then have to worry about the off effect or the rebound in remodeling upon stopping denosumab, and probably the bone density response to the second course of anabolic therapy, in theory, should be better following a bisphosphonate than following denosumab. And to extend that even further, I might actually make the active decision to choose risedronate rather than alendronate or Zal as the bisphosphonate for the 12 months between the romosozumab doses.
Thank you. Now we have questions from Dr. Almoyaya and Dr. Poham, which are quite similar. They are asking, after discontinuation of denosumab, which dose of zoledronic acid will you give? Like the standard one or a different one?
Again, the only experience that I'm aware of is giving the standard 5 milligram dose. And again, I think Dr. Langdahl's studies have shown clearly that if we do that, that many patients can be managed with that single dose, and but that we should monitor all the patients carefully and consider a second dose of the same amount at 3 or 6 months after the initial dose if there's evidence that the first dose isn't adequately controlling the rebound in remodeling.
And if you are giving alendronate, what will you recommend?
Again, I think the standard 10 milligrams a day or 70 milligrams a week, that's the dose we used in our study, showing that after 1 year of denosumab, 70 milligrams of alendronate effectively prevented bone loss. In none of the phase 2 studies that we've ever done is giving more bisphosphonate more effective, with the exception of patients with cancer-related bone disease. Whether that would make a difference after discontinuing denosumab, I honestly don't know, but I would not expect that higher doses would necessarily be more effective.
And another question from Dr. Cockhill, maybe a difficult one too. She mentioned that also it is not advised to switch from denosumab to teriparatide. Is it sometimes necessary?
I can't imagine a situation where it would be mandatory. I have had patients who were on denosumab and who I thought deserved an anabolic agent, and this is 2 or 3 patients. And what we've done was to start teriparatide while continuing denosumab, rather than making the switch, but adding teriparatide to denosumab, much in the same way that Dr. Kosman has argued that adding teriparatide to a bisphosphonate is more effective than switching from one to the other.
Thank you. Dr. Misch is asking whether do you have any opinion whether one could perform a sequence, for example, of teriparatide for 12 months and directly after 6 months of romosozumab? So an anabolic sequence after an anabolic, another anabolic one.
That's an interesting question that many of us have speculated about. Again, there is a small study from Japan, I think blocking on the first name of the author, but published just in the last year, that looked at the effect of romosozumab as a function of pre-treatment. So they looked at patients who were treatment naive, patients who had been on bisphosphonates, patients who had been on denosumab, and a few patients who had been on teriparatide and made the switch directly. And in the small group that switched from teriparatide to romosozumab, there was an increase in bone density, not as great as was seen in the treatment naive group. So I think that's a possibility. It's interesting to think about that mechanistically, since the anabolic stimulus of romosozumab is quite different. The mechanism of the anabolic stimulus is very different than the mechanism of a PTH analog, with romosozumab having a profound effect on activating modeling-based bone formation, which happens to only a limited extent with teriparatide. So it doesn't surprise me, or would not surprise me, to see an additional anabolic benefit if the switch from teriparatide to romosozumab was made. But again, we have very, very limited evidence to support that idea.
And maybe the last question from Dr. Bélanger, who is asking, after taking alendronate for 5 years, followed by another medication, can you switch back to alendronate?
I think so. Again, as I said, I think that the final drug in any sequence will be a bisphosphonate, either alendronate or zoledronic acid. So again, what that means in terms of either efficacy or safety has not been adequately evaluated. The studies from both the evidence from both the Swedish study of Silcher and the California study by Dr. Dell suggest that the risk of atypical fracture appears to decrease quite substantially over the first year or two following discontinuation of a bisphosphonate. If that's true, then the question is, if you restart a bisphosphonate, has the clock started over about atypical fracture risk, or does the previous 5 years of therapy still count? And I think no one knows the answer to that question.
Thank you very much. I think now it's time to conclude. I'm sorry, but we really don't have time to answer all the questions. I would like to thank you all for your participation in this webinar, and we hope that you enjoyed this session. We will post the recording of the webinar on the IWEF website, and you will receive your certificate of attendance and the link to the recording by email tomorrow. You will be prompted to fill in a survey immediately after this webinar. We would appreciate your input and comments. And if you have any questions, comments, please do not hesitate to send them at the address webinar@osteoporosis.foundation. I would like to thank you again, Dr. McClung, for your outstanding talk. And I hope you will be with us next month, all participants. Goodbye, everyone.
All right, goodbye.
Goodbye, and thank you.